Welcome to the Deep Dive, your shortcut to being genuinely well-informed. Today, we're plunging into one of the most fundamental human experiences, pain, especially when you're at your most vulnerable. We're talking specifically about pain management of the intensive care unit, the ICU, and how it's actually undergoing a pretty significant transformation, a revolution, really.
It really is.
So this Deep Dive, it's all about innovating pain management in critical care beyond opioids.
Yeah.
And it's just incredibly complex, isn't it?
Absolutely.
I mean, each patient shows up with their own unique medical history, and then you add all the existing health issues. It's getting pain control right extremely difficult.
Yeah.
And the stakes are just so high. Get it wrong, and you're looking at serious stuff like delirium, heart problems, even a weakened immune system.
That's right. And what the research is consistently pointing towards, and this is the really transformative part, is this crucial paradigm shift. It's a very deliberate move away from what used to be an opioid-centric model.
Relying mainly on those strong painkillers.
That's exactly. Towards something much more comprehensive. This new strategy, it combines what we call multimodal analgesia, basically using different meds and non-drug techniques that work in different ways with these standardized assessment-driven protocols using validated pain scales.
Okay.
The goal here is, well, it's profound. It's about drastically cutting down opioid use, minimizing those really nasty side effects, and fundamentally improving patient comfort and, their overall recovery, even for patients who are so sick they can't speak for themselves.
Right.
So it's not just about using fewer opioids. It's really a fundamental shift in how we think about pain, like moving from a sort of blunt force approach to more of a precision strike.
Targeting the pain pathways differently.
Precisely, like a multi-pronged attack. And that ultimately means a much less traumatic recovery for the patient, which is what we all want.
Okay, so if the stakes are that high, and the old way of doing things isn't really working anymore, let's unpack this a bit. Why is pain management in the ICU setting just so uniquely challenging? It sounds like it's way more than just handing out a painkiller.
You're absolutely right. It's incredibly complex. Think about it. Every single patient brings this unique mix of what the research calls sociodemographic, pharmacokinetic, and pharmacogenomic variables.
That's a mouthful.
It is. But it basically means things like their age, their background, how their body processes drugs, that's the pharmacokinetics, and even how their own unique genetic code, the pharmacogenomics, influences how they respond to medication.
Okay.
Then you add on top of that pre-existing issues, maybe psychosocial ones like depression or anxiety or other medical problems. These can seriously amplify how someone experiences pain.
Wow.
And critically ill patients, they're not just hurting from, say, a big surgery.
Right.
They often experience pain just lying in bed, at rest, or during totally routine ICU care, like being turned or having a simple procedure done. It's a constant battle.
And I imagine it's not the same for everyone. Like a one-size-fits-all approach just wouldn't work.
No, definitely not. Studies actually suggest that younger patients, women, and individuals who are non-white might be more likely to report really intense pain.
Interesting.
But then on the other hand, older patients might actually have a decreased perception of pain sometimes, yet they're often much more vulnerable to the side effects of the medications we use.
Right.
So it really is this minefield of individual differences. You absolutely need a highly tailored approach.
So what happens if we don't get it right? You mentioned some serious consequences, but what are the real costs of not managing this pain adequately?
The costs are incredibly high, and they go way beyond just feeling uncomfortable. Untreated or undertreated pain is a major contributor to developing delirium.
That state of acute confusion.
Exactly, and it can have really long-lasting cognitive effects. Pain also messes with the heart, causing cardiac instability. That means dangerous swings in heart rate, like too fast, which is tachycardia, or too slow, bradycardia. And blood pressure issues too, hypertension, so high blood pressure, or hypotension, low blood pressure. We also see respiratory distress, things like desaturation, where oxygen levels drop, or bradypnea, which is abnormally slow breathing.
Which must be terrible if someone's already on a ventilator.
Absolutely. Ventilator distress. It severely complicates recovery for those patients. And, maybe surprisingly, it can actually suppress the immune system, making patients more vulnerable to infections.
All right.
And here's a really critical point. Vital signs. Things like heart rate, blood pressure, breathing rate, oxygen levels. They are not considered valid indicators for pain on their own in critically ill patients.
Really? I think most people assume if your heart rate goes up, you're in pain.
It's a common misconception. They can be cues, sure. They might prompt us to look closer to do a proper assessment, but they are definitely not definitive proof of pain. Relying only on vitals can lead to dangerous undertreatment.
Okay, that's a huge takeaway. So if relying just on opioids and checking vitals isn't the answer, what is the core solution experts are pushing for, this multimodal analgesia you mentioned?
Yes, multimodal analgesia. It's really the cornerstone of this whole new approach. The basic idea is integrating two or more different drug classes or even non-drug techniques that target multiple pain pathways.
Okay.
And they each have a different mechanism of action, how they work. The goal is to get a synergistic or maybe an additive effect.
Meaning the combined effect is bigger than the individual parts.
Exactly, which often allows us to use lower doses of each individual medication, reducing side effects. It's a comprehensive toolkit, really. It includes opioids, yes, but used much more judiciously.
Right.
Plus non-opioid analgesics, things like NSAIDs or gabapentinoids. Then you have regional or neuraxial blocks.
Those are the targeted nerve blocks.
Yeah, injections near nerves or the spinal cord to numb specific areas. And importantly, it also includes nonpharmacologic therapies, things that aren't drugs at all.
That makes a lot of sense. It sounds like building a multi-layered defense against the pain instead of just one weapon.
That's a great way to put it.
But why is moving away from opioids specifically so critical? What are the major downsides of just sticking with those powerful drugs?
Well, what's really fascinating and kind of alarming is why this shift matters so much. The primary benefit of multimodal analgesia is that you can significantly reduce how many opioids someone needs while still keeping them comfortable or maybe even more comfortable.
Okay.
And that's a total game changer because the old opioid-centered approach, I mean, yes, opioids are potent. They work effectively at those mu receptors in the brain for pain relief, but they come with this massive list of short-term side effects. We're talking physical dependence, respiratory depression, where breathing slows down dangerously ileus, which is where the bowel basically stops working, leading to severe constipation.
That sounds awful.
It is. It affects a huge number of patients, maybe up to 81% in some studies. Then there's nausea, vomiting, being overly sedated, pruritus, that's intense itching urinary retention. It's a long list.
And those are just the short-term ones.
Right. Then you have significant long-term consequences. Things like addiction, obviously, but also immunosuppression, like we mentioned, and even something called opioid-induced hyperalgesia.
Where the opioids make the pain worse.
Ironically, yes. They can actually make patients more sensitive to pain over time. And these side effects, they're not just unpleasant. They can genuinely prolong how long someone stays in the ICU and worsen their outcomes even after they leave. It just highlights why we urgently need to move beyond relying solely on them.
Okay, that really paints a clear picture. Now, here's the crucial bit, I think. How do we actually personalize this? If every patient is so different with all those variables you mentioned, how do we tailor this complex multimodal approach consistently and effectively for each person?
That is the million-dollar question, isn't it? And the answer lies in really robust pain assessment. It has to be foundational. We're talking about using assessment-driven, standardized pain management protocols.
So moving away from just guesswork.
Absolutely. Relying on validated tools, tools that have been scientifically tested and proven to work. That's how we tailor the strategies.
Okay, tell us about these validated tools. How do they actually work, especially for patients who might not be able to just tell you their pain score?
Right. So for patients who can communicate their pain clearly, the numeric rating scale, the NRS, rate your pain from 0, that's common.
Sure.
But increasingly, we're seeing the Defense and Veterans Pain Rating Scale, or DVPRS. It's also a 0-10 scale, but it visually includes facial expressions and colors that correspond to the pain intensity.
Oh, interesting. So it gives a visual cue, too.
Exactly. And what makes it particularly useful are these supplemental questions. It asks how much the pain is interfering with the patient's usual activity, their sleep, their mood, even their stress levels.
So you get a much richer picture than just a number.
A much more holistic picture, yes.
Yes.
Now, for those critically ill patients who can't self-report, maybe they're intubated on a ventilator or they have cognitive impairments, we have to use observational tools.
Okay.
The key ones are the Behavioral Pain Scale, or BPS, and the Critical Care Pain Observation Tool, CPOT. The BPS looks at 3 things: facial expression, upper limb movements, and how well they're coping with the ventilator. Scores range from 3 to 12, and a score over 6 generally means unacceptable pain.
Got it.
The CPOT is similar. 4 domains: facial expression, body movements, muscle tension, and ventilator compliance or vocalization for non-intubated patients. Each scored 0.2, total 0.8. A score of 3 or more suggests pain.
It's actually brilliant how these tools let us listen to pain even when someone can't speak.
It is. And these standardized protocols using these tools consistently, they are proven to improve ICU patient outcomes. And they consistently decrease both opioid and sedative consumption.
Awesome.
By preventing both extremes, they help prevent undertreatment in those really vulnerable patients, but also stop us from over-administering medications in others. It's about finding that right balance.
That makes perfect sense.
Okay.
Okay, so we have better assessment, multimodal medications. What else is in the toolbox? Beyond the drugs and scales, what else helps provide comprehensive pain relief? You mentioned non-pharmacologic options earlier.
Yes, absolutely. And this is where we really broaden the approach. These non-pharmacologic modalities are often, inexpensive and generally very safe. That makes them excellent additions to a well-rounded pain plan.
Like what?
Well, music is a great example, and it's kind of broken down into 2 types: music medicine and music therapy. Music medicine is simpler, using pre-recorded music to help someone relax, distract them, maybe alleviate tension.
Okay.
Music therapy is more involved. It uses a trained therapist who actually interacts with the patient, using music in a more holistic way. And studies, even small ones, show these can have small to moderate effects in reducing opioid use and pain perception.
Even for patients on ventilators?
Yeah. Even for mechanically ventilated patients, yes,
Oh.
which is pretty incredible.
Wow, that is incredible.
Yeah.
What other non-drug approaches are showing promise?
We also see benefits from cognitive behavioral modalities, things like hypnosis, guided imagery, and various relaxation techniques. These have actually been proven to help with postoperative pain and reduce the need for analgesics, with very minimal risk of harm.
Interesting.
Other things that are promising, generally safe, and not too expensive include aromatherapy. Lavender essential oil, for instance, has shown some benefit for anxiety and sleep in critically ill patients. And then you have physical modalities, things like acupuncture, using cold or heat therapy, massage. These also hold potential, although admittedly the robust, specific evidence for their use right in the ICU setting is still developing for some of these.
Right. But it's so important, isn't it, to stress that these aren't just nice extras. They sound like vital parts of a truly complete strategy. They acknowledge that pain isn't just physical. It has those psychosocial and emotional sides too, which we often overlook if we only focus on pills.
Absolutely. Acknowledging the whole person, the whole experience of pain is key. But this also brings up an important point: attention, really.
Okay.
If these newer, broader approaches are so beneficial, why isn't everyone just doing this perfectly already? Why isn't it a completely straightforward switch? One of the main tensions is that historical reliance on opioids versus the now urgent need to limit their use.
Right, the old habits die hard.
Sort of. For a long time, opioids were the main tool for non-neuropathic pain in critically ill patients. Why? Because they're highly potent and they work fast. That's appealing in a crisis.
Understandable.
But now, as we've just laid out, the focus has drastically shifted because we understand the numerous severe side effects much better, so we have to limit opioid requirements. This creates a real dilemma, though.
How so?
How do you effectively leverage a potent, fast-acting pain reliever when you absolutely need it, while at the same time mitigating all those well-documented harmful consequences? Especially when someone's life might be hanging in the balance. It's a tough clinical judgment call.
That's a profound challenge for clinicians on the ground. And that leads right into what sounds like the second major tension the research highlights. This gap between the potential benefits of all these non-opioid and non-pharmacologic options and the lack of really solid evidence for using them widely, specifically in the critically ill ICU population.
Exactly. That's the other big hurdle. While many of these therapies, certain muscle relaxants, ketamine, lidocaine infusions, alpha-2 agonists, those physical modalities we mentioned show promise or are used effectively in other areas of medicine.
Yeah.
The literature specifically looking at them in critically ill ICU patients often describes the evidence as scant or minimal data, maybe unclear or simply currently unknown.
So the proof isn't quite there yet for this specific group.
For many of them, not robustly enough for widespread guideline-backed adoption. And this isn't just, an academic debate. It creates a real problem for doctors working in the ICU. They see the potential, they want alternatives to opioids, but without strong data confirming efficacy and safety in this specific complex population, it's really hard to justify adopting them universally, especially in such a high-risk environment.
Can you give us a concrete example of that evidence gap, just to make it really clear?
Sure. Let's take those physical modalities again. Heat, cold, massage. Generally, they're inexpensive, they're safe. Seems like a no-brainer, right?
You'd think so.
But despite their theoretical plus points, current major guidelines actually neither recommend nor discourage their use specifically for post-operative pain management in general, let alone ICU patients. Why? Because the impact seems highly variable in studies, and there just aren't enough good quality studies focused specifically on ICU patients. So it really highlights this significant gap. We have these theoretically great ideas for diversifying pain management, moving beyond opioids, but we're missing the concrete ICU-specific evidence needed to confidently integrate them into everyday clinical practice everywhere. We simply need more targeted research.
Okay, so there are definitely tensions and a need for more research, but despite that, the future isn't just about managing pain better. It sounds like it's about truly innovating it. So what's on the horizon? What's the really exciting stuff coming down the pipeline for personalized advanced pain care in the ICU?
Yeah, this is where it gets incredibly exciting looking forward. The research points to several really compelling novel directions. First off, there's a huge opportunity for advancing truly personalized, data-driven opioid reduction strategies.
Using all that patient data you mentioned earlier.
Exactly. Leveraging individual patient data, those socio-demographic factors, how they metabolize drugs, pharmacokinetics, their genetics, pharmacogenomics, to actually predict how an individual might respond to different pain meds. And, crucially, predicting their specific risk of developing those opioid-related side effects.
Wow.
Imagine being able to develop highly customized multimodal pain plans from the outset. Proactively using non-opioid options or maybe regional anesthesia, specifically chosen to minimize opioid exposure and maximize safety based on that patient's unique biological profile.
That's essentially precision medicine, but applied specifically to pain management in the ICU.
Precisely. That's the goal.
Mm.
Then the second big area is expanding the use of regional anesthesia.
The nerve blocks.
Right. We know they offer great pain relief and can even improve lung outcomes, which is huge in the ICU, but they remain pretty underused in critically ill patients.
Why is that?
Mostly due to perceived contraindications, worries about things like hemodynamic instability, unstable blood pressure or coagulopathy, blood clotting problems, which are common in ICU patients. Okay.
So this presents a really clear opportunity for innovative research. We need to develop safer techniques, maybe new protocols to mitigate those risks. If we can do that, regional blocks could potentially become a real cornerstone of multimodal pain relief for a much broader group of ICU patients. It's untapped potential.
Untapped potential, definitely.
Yeah.
And finally, you mentioned something that sounded truly transformative, especially for those patients who can't communicate at all.
Absolutely. This could be a genuine game changer. Given how difficult it is to assess pain accurately in unresponsive or paralyzed patients using current methods, those behavioral scales just don't work well there. The development of objective pain biomarkers is critical. Measuring pain objectively with a device.
Essentially, yes.
Okay.
There are promising technologies being developed right now, things like measuring heart rate variability, using tools like the analgesia nociception index, or ANI. Another approach integrates several physiological signals into something called the nociception level index, or NOEL index.
Yeah.
And another fascinating area is looking at the pupillary reflex, how the eye's pupil responds to stimuli using video pupillometry. Changes in pupil size can correlate with pain or stress levels.
And these objective biomarkers,
Yeah.
wow, they really hold the most transformative potential, don't they? To finally revolutionize how accurately we assess pain for the absolute most vulnerable ICU patients. Moving beyond subjective interpretation or just observing behavior into a new era of precision. Imagine if we could literally see a patient's pain level on a monitor.
That's the ultimate goal. So to sort of wrap up our deep dive, I think the overarching message is really clear. This shift away from just relying on opioids towards a comprehensive, individualized pain management strategy isn't just a minor tweak. It's a crucial evolution in critical care.
Right.
And it absolutely relies on using those validated assessment tools consistently, employing sophisticated multimodal approaches tailored to the patient, and smartly integrating those non-pharmacologic options to genuinely improve how patients feel and recover.
So, for you, our listener, if this topic has grabbed your interest and you're thinking about what the next step might be, based on everything we've discussed today, perhaps the most important next step is this. Actively engaging, whether through research, advocacy, or just awareness, for the robust validation and the systematic integration of these novel, objective pain assessment technologies, and pushing for more evidence on those diverse, non-opioid, non-pharmacologic strategies specifically within the critically ill ICU population. This focus on evidence-based expansion, moving beyond the traditional methods, is absolutely essential if we want to truly personalize pain care and improve outcomes for these incredibly vulnerable people. Think about the profound impact these innovations could have on real lives in the ICU. That's definitely a future worth investing our attention in.